All right, if I could have everybody, please, we're going to start.
Strangely enough, we're pretty well on schedule here, and
Hey!
we're going to go into a little bit more depth now on some of the details of therapy. We have a lot of exciting new treatment options, and sometimes it can be a little bit confusing, but as we touched on yesterday afternoon, it can be relatively straightforward in an individual case to settle on one regimen versus another. And so I'm especially pleased to start off this discussion with Dr. Shaji Kumar from the Mayo Clinic, who has a particular interest in the novel therapies and has also been analyzing the impact of novel therapies in the last 10 years or so. And I think he'll probably be showing you that what's been especially rewarding has been to see that we're starting to see an impact with therapies in patients who are over the age of 65 who may not have had a transplant. We're starting to see an impact with the novel therapies in this population. So please welcome Dr. Kumar to discuss new options for patients like this.
Good morning, everyone, and thanks for inviting me here, Brian. It's always a wonderful experience to be at one of these patient seminars because you always hear questions that you typically don't hear in the office, and it often stimulates thoughts and ideas and more things to do, I guess. So what I'm going to try and focus on is how things have changed for the treatment of the older patient with multiple myeloma. Now, obviously, the definition of who is old and young is like beauty, right? It's in the eye of the beholder. But what we know is patients with multiple myeloma are clearly living longer. And we know that from our own experience, from multiple studies that have looked at national databases, as well as studies from other countries. And we've seen this particularly so in the past in the past decade is when we have really started seeing this improvement in the survival in patients with multiple myeloma. But however, this picture here, even though it looks good, does hide a very important fact, and that is what we can see here. On the left-hand side, you can see how patients who are under 65 have done during this time period, again in 6-year blocks, a significant improvement over time. However, when you look at the patients who are over 65 years of age, it is a lot less rewarding when you look at the differences over time. So why are we concerned about that particular aspect? And I think the answer lies in this. If you look at whether it's a Mayo Clinic data or the SEER, which is the national database data, you can see that almost half of the patients with multiple myeloma are over 70 years of age. And that is what we see in the clinic as well. So clearly, we are talking about a substantial proportion of patients with myeloma who are older than 65 or older than 70, wherever you want to draw the line. So clearly, we need to really focus on these patients and find out why are those patients not doing that well, and then only can we improve the outcomes of patients overall. So one of the things is just the age. We know that patients who are older don't do as well as patients who are young with myeloma. And this is the result that was, again, a large group of patients that were studied in the International Myeloma Working Group, or the IMF, and also the similar results from the patients whom we have seen at Mayo Clinic over years. Now, why is it that older patients don't do well as patients who are younger? There are multiple reasons for that, and I'll try and go through some of them. One of the biggest factors is these patients often have other illnesses and other comorbidities that come along with aging, which can have significant impact on how the myeloma presents and what kind of complications you get, and also limits what kind of treatments you can actually get. Patients who are older, they are less likely to go to the large referral centers and institutions with more experience treating patients with myeloma. They're less likely to go on clinical trials, which sometimes gives you the option of something that is new and maybe the next best thing that's going to be out there. they're less likely to tolerate full doses of medications because of side effects. And also many of these medications that we use require good organ functions to be able to kind of break them up so that people don't get side effects. So older patients don't metabolize or break up those medications as well as the younger patients. And we often see that the older patients tend to have more side effects to many of the treatments that we use. Now, for example, let's just take a look at the other health issues, right? For example, diabetes is not an uncommon thing in patients who are over 70. And the problem is dexamethasone is a part of almost every therapy that we use for this disease. And as many of you would have experienced, once you go on the steroid medications, your diabetes just goes haywire. Your endocrinologist starts pulling out his or her hair just looking at the numbers. The kidney disease is something that can be part and parcel of the myeloma, but it can also limit the doses of medications that we can give. Many patients have vascular disease, whether it be coronary artery disease or they have had strokes, and some of the medications that we use in this disease can increase the risk of blood clots, and that can exacerbate this problem. Neuropathy can be there because of diabetes or some of the pre-existing conditions, and some of the medications we use, like thalidomide and Bortezomib, can further make the neuropathy worse, or maybe even limit our ability to use some of those medications. Osteoporosis is a very common thing in the older patients, and you give them dexamethasone on top of that, it doesn't help things. And myeloma itself also tends to make the bones worse, as you will hear later on today. But there's also one other reason. It's not just old being a number. You're more than 65 or more than 70. There's something that is very critical about in terms of the treatment of this disease that also makes us think about the age. And that is the use of stem cell transplant. And you will hear from Dr. Stadtmauer in the next talk about some of the transplant options in the treatment of myeloma. We know that it's a very effective treatment. Most of the studies that have been done had used an age of 65 as the cutoff for whether to use transplant or not. And because of those results of those studies, we have always thought about, okay, the older patients, we cannot transplant them. The younger patients, we can transplant them. So we need to be approaching them in a different fashion. And that's why the traditional way of looking at that was the first question we would ask ourselves whenever a new patient with myeloma came in was, can this patient go through a stem cell transplant? And depending upon the answer to that question, we would decide what kind of treatment to use, whether it's something to do with Melphalan or whether it's some treatment that does not prevent a future transplant. And then a vast majority of them would get a stem cell transplant either right away or at a later time point. So, but that thing has changed now. We always, the older patients is not necessarily meaning transplant ineligible patients. Now we have a wealth of experience over the years where we have transplanted patients between 65 and 75 or even sometimes over 75 who have done very well with the stem cell transplant. So it's not that you want to draw a line in the sand based on age, but you want to really look at how well the person is overall. And the other thing that we always, that has changed over time is the fact that many of the drugs we use today does not affect the ability to collect stem cells, like what the Melphalan or any of the other older drugs would have done. So that picture that I just showed you has kind of changed. We don't necessarily think about whether somebody is transplant eligible or not right away in the beginning. Instead, we start thinking about what kind of a risk that patient has in terms of the genetic abnormalities that we can see in the myeloma cells. And based on that kind of risk stratification, we would decide what kind of treatment to give. And once the patients start feeling better, the myeloma is under good control, that's when we start talking about, should we be thinking about stem cell transplant, whether it's done right away or we just collect the stem cells and do the stem cell transplant at a later time point. And I won't go into the transplant discussion too much because Dr. Stadtmauer is going to be talking about that. But then what are the different tools that we have in terms of controlling the multiple myeloma? Now, everybody in the room, I'm sure, have heard of and is familiar with Melphalan. It had been the workhorse of myeloma therapy for decades. And we knew that with just Melphalan and Prednisone, patients would, on an average, live for about 2 to 3 years from the time point they were diagnosed with myeloma and started on therapy. Now, that was 10, 15 years ago. That has all changed. So the question that we all were asking over the past decade was, how can we make the Melphalan and Prednisone work even better? And when all the new drugs came along, that gave us the opportunity to test that question. So as you can see here, a large number of clinical trials were done asking the question whether adding thalidomide to the melphalan and prednisone, would that make things better? So if you look at how long the myeloma stays away after treatment, which is the progression-free survival, you can see in the vast majority of the trial, adding thalidomide was better than the melphalan and prednisone. Not only was the myeloma kept away longer, patients also lived longer. And if you look at the cumulative overall results of these trials, looks like adding thalidomide to the melphalan is a good thing. So obviously, we were all very enthusiastic about looking at these results because we finally had something that worked better than melphalan and prednisone. But we also want to realize that, especially in the older patient population where the study was done, adding new things may be good in terms of controlling myeloma, but it also comes with a cost. As you can see here, in the patients, for example, peripheral neuropathy, if you look across the studies, adding thalidomide led to a significantly higher risk of getting peripheral neuropathy. It also led to a higher risk of getting thrombosis or blood clots when you add the thalidomide to melphalan prednisone. So it's always a balance between what kind of toxicity or side effects you see and what kind of efficacy you see with your therapy, with your treatment. So the next question was, can we add Velcade or Bortezomib to the melphalan prednisone combination? And this was a trial that was done by across the world, again looking at the question, can we add Bortezomib to the melphalan prednisone backbone and make patients better? And they were able, Dr. Stadtmauer was able to show that the patients who got the combination of Bortezomib with melphalan and prednisone lived longer compared to the patients who did not get the Bortezomib. So, and this study has since been updated, and we know for sure this is a result that has kind of withstood the test of time and is still is relevant. The other question was, the third new drug that we had in the clinic was the lenalidomide or Revlimid, as many of you would know it. And this study by Dr. Palumbo, what he did was he took the melphalan prednisone, he added the lenalidomide to that, which is this orange line, or you added that, not only just added the lenalidomide to the melphalan prednisone, but also kept these patients on the lenalidomide or Revlimid for a long time until the disease came back. And he was able to show that the disease was kept at bay for a much longer time by using that addition of lenalidomide. Even though at this point we could argue it's relatively early on, we still don't see any differences in terms of how long patients lived depending upon the use of lenalidomide. But then, all these results kind of brought up the question, melphalan is a good drug. We know it works well, but we also know it has some side effects. It can make your blood counts go down, and sometimes it can also limit the ability for us to give these new drugs later on in the course of the disease. So we want to ask the question, do we really, really need that melphalan there, or can we think about using that at some other point in the time? Now, if going backwards, when we look at this ECOG study where they looked at patients getting lenalidomide and 2 different doses of dexamethasone, what we were able to see was that in the patients who are over 70 years of age, they kept the myeloma away for roughly 2 years, and at 3 years, nearly 3/4 of the patients were still alive despite the diagnosis of myeloma, which is much better than what we had historically seen with the older drugs. And this was directly asked in a large study that was presented at the recent ASH meeting, where the French group basically took roughly about 1,500 patients and put them in 3 groups. They got either the Revlimid and dexamethasone until the myeloma came back, or they gave it for only about 18 cycles, which is roughly about a year and a half, or they used the old one, which is the melphalan prednisone thalidomide, which was the result of the previous studies that I just showed. And what they were able to show was when they gave the lenalidomide and dexamethasone, patients had a better response. They had more patients getting a deeper response, which is the very good partial response or better. And also, it was a very fast-acting therapy compared to the melphalan prednisone thalidomide. And compared to the melphalan prednisone thalidomide, a short duration of lenalidomide dexamethasone, these patients actually had the myeloma stay away for roughly about 3 years. And this is what is again depicted in this figure, the green line being a continuous therapy with Revlimid and dexamethasone compared to the other 2 strategies. However, when you look at the overall survival, clearly when you compare that with the melphalan prednisone thalidomide, giving the lenalidomide dexamethasone was a much better strategy and actually allowed patients to live longer. What we still don't know the answer to is whether we can give lenalidomide dexamethasone just for 18 months, or do we need to keep giving it until the myeloma came back, because we still don't see much of a difference between those two groups yet. And part of it is many of these patients who may get 18 months and go off and the myeloma comes back, they can go back on the same treatment and may be able to control the disease almost as effectively. So that is a question I think only time will tell us. Now that the lenalidomide dexamethasone we know is a very good treatment for the older patient with multiple myeloma, then kind of going back to the same question, do we really need anything else added to that? So Dr. Palumbo looked at that question. So lenalidomide dexamethasone, he added the Melphalan to the Melphalan Prednisone Revlimid, or the Cyclophosphamide Prednisone lenalidomide. And this is data that he presented at this most recent ASH meeting. So patients were randomized to one of these groups by chance, and then at the end of this treatment, they were again, by the flip of the coin, either continued on this kind of maintenance therapy with just Revlimid or with Revlimid and Prednisone. So he was trying to ask two different questions here. What he was able to show was, irrespective of what is the type of treatment that you started off with, about half of the patients were still free of the myeloma, or the myeloma had not come back at 2 years from the time of the treatment start. And about 80% of the patients were alive 2 years from the time of the diagnosis, irrespective of whichever way we went. And we know that the side effects are higher when you add more medications to this backbone of Revlimid and dexamethasone. So I think this study in a way tells you that we don't necessarily need to have that Melphalan in the beginning. We could just go with some of these newer drugs like either lenalidomide dexamethasone or Bortezomib dexamethasone for the newly diagnosed patients. So the same question was again asked by, in a different study. Again, patients were either given Velcade and Prednisone, or they were given Velcade, Prednisone, and Melphalan, or Velcade, Prednisone with cyclophosphamide. And at this point in time, again, is very early on, we don't really see a whole lot of difference between these group of patients in terms of the overall survival or the progression-free survival. But I think, again, what it really tells us is that, yes, these new drugs like Revlimid or the Velcade, they are very important in terms of the initial treatment of patients, the older patients with multiple myeloma. We don't necessarily have to use the Melphalan right in the beginning in combination with these, because there are some long-term side effects with the use of Melphalan, which can limit what other therapies you can get down the lane. Now, what about other regimens that have been used or treatments that have been used in patients, in the older patients? A good example is this combination of cyclophosphamide, thalidomide, dexamethasone that the UK group, Dr. Morgan's group, had looked at. And again, they were able to show that this combination with some dose modification was as good as the traditional Melphalan and Prednisone combination, as you can see here, in terms of their ability to keep myeloma away, as well as keep and allow patients to continue with these treatments. There are other treatment combinations that have been used. There is always the Bortezomib in combination with cyclophosphamide dexamethasone. There is the Bortezomib, cyclophosphamide, and Prednisone. The cyclophosphamide has been combined with lenalidomide and dexamethasone, and then the Bortezomib has also been combined with Revlimid or the VRD regimen, which some of you may have had. But I think where the field is kind of moving towards in terms of the older patients with myeloma, I think the Melphalan has kind of taken a backseat. I think we are starting to use more of the cyclophosphamide, which we think is a more gentle version of the Melphalan, especially in combination with some of the newer medications. What about the really new medications, the ones that have come up over the past year? Now, Pomalidomide, again, some of you may have had it in clinical trials, and some may have received it since it was approved late last year. And in this study that was done, large study where patients got either the Pomalidomide with dexamethasone or just dexamethasone, patients who got the Pomalidomide dexamethasone clearly lived longer, telling us that the Pomalidomide is an effective drug. It can control the disease and can reverse some of the problems associated with the disease. What about Carfilzomib? That's the other new drug that has been approved in the past year. Now, Carfilzomib and Velcade belong to the same class of medications. The Pomalidomide and the Revlimid, they belong to the same class of medications. Now, in the Carfilzomib, again, I just want to highlight, if you just look at the group of patients, depending upon their age, patients who are less than 65 and patients who are more than 65 years of age, they do both of them do get benefit from being treated with Carfilzomib. And again, this is basically the proportion of patients who are getting a good response to the therapy. So even in the older patients, we may need to have some dose adjustments, but they still benefit from getting this therapy. I just want to briefly mention another drug called Bendamustine. Now, this is not a new drug, fancy drug. It's been around for several decades. It's just that it's kind of finding a new use in multiple different cancers. And it has already been approved for treatment of some of the other leukemias, so like chronic lymphocytic leukemia. Now, several of us have studied this drug, both in combination with other drugs. Dr. Lynch has studied it in combination with lenalidomide. Others have done combinations with Bortezomib. And what we know is that it's an effective drug, and it is something we certainly want to keep in our mind when maybe some of the other drugs have stopped working. Now, one of the things that has become more obvious over the years is we can't just treat everybody the same way. And I think we talked about the older patients they having a different approach to the therapy. And we went over some of the reasons why that is so, some of the things that come with age, but also we want to learn about and we want to do the treatments in a little different fashion. And what do you mean different fashion? Now, this is something that Dr. Palumbo and his colleagues had put together, looking at the various risk factors. So if you look at people over age 75, whether they are frail in terms, again, defined in terms of how much of help they need with their day-to-day activities. Also, counting in the various other illnesses they may have. And if you take all those things and we basically group those patients into 3, depending upon all the presence or absence of these things. And if you have none of these risk factors, I think we can treat them just like we would treat younger patients. If they have at least one of these problems, then we have to scale back our treatment a little bit. And our doses have to be dialed down. And if you have multiple of these problems, then we really have to dial down the dose even further. Now, you may all wonder, okay, are we going to actually lose out by dialing down the dose of these medications? I think in the long run, it does not, because if we try to treat these older patients with the full doses of drug, what's going to happen is we're going to run into side effects, and then we anyway end up decreasing the dose of medications, or even taking them completely off the medications, which I think in the long run is more harmful than trying to treat them with lower dose of drugs, which they can actually tolerate. What about stem cell transplant? Again, as I mentioned in the beginning, the age cutoff of 65 is something that's come from clinical trials, but it doesn't have to be that. We can use high-dose therapy or stem cell transplant in even patients older than 65, as long as we are very careful about whom we choose to take to transplant. And how we choose that is dependent on, again, do they have multiple other medical problems? Are they in relatively good health? And of course, whether they even want to go through a stem cell transplant. And this is, again, information from our own group as well as others showing that if you compare that to younger patients, the selected patients over 70 years of age almost get as much benefit from a stem cell transplant. Clearly, in those older patients, we do decrease the dose of the medications we use for the stem cell transplant. Now, I just want to briefly touch upon a concept that is increasingly part of the debate or the discussions that we have across this disease, which is the role of maintenance therapy. Now, how we define maintenance therapy, again, is kind of fluid. Some would consider maintenance therapy is just continuing with the same treatment, even though theoretically we think about maintenance therapy as something where we kind of scale back on everything, use a small dose of one drug, and to try and keep the disease under control. Now, just as we have used the maintenance therapy after stem cell transplant over years in the context of different clinical trials, increasingly the clinical trials that are looking at the older patients, we are asking the same question. Is there any benefit in just continuing the therapy instead of stopping it at a defined time point, let's say 12 months or 18 months? So I won't go into the details of many of these studies, but this is one study that was done by Dr. Palumbo looking at Velcade, Melphalan Prednisone, thalidomide versus Velcade, Melphalan, and Prednisone. And then he continued these patients on the maintenance therapy with thalidomide beyond the initial 18 months of treatment. And he was able to show that the myeloma stayed away for a longer time period by giving maintenance therapy. But just like in the transplant setting, we still don't have the final answer to whether this maintenance therapy is going to make patients live longer, or is it just going to keep the disease away for longer. So I think we always have to balance the the efficacy against the possibility of getting more side effects by keeping patients on maintenance. So I think we'll hopefully in the next few years, as some of these large studies give mature results, we should be able to give an answer to that question. Now, even though I put all of this in one slide, supportive care is very critical for the management of patients with myeloma. And I think a lot of the progress we have made over the past decade, even though we think it's all the new drugs, I would argue that supportive care is also playing a big role in that. So bond strength, we know that the use of bisphosphonates significantly decrease the risk of patients getting bone problems or fractures. Not only does it help bonds, it actually helps keep myeloma away as well, as was shown by the UK group, where patients who got the Zomida or the zoledronic acid actually lived longer than the ones who got a different type of bisphosphonates. So I think right now patients with multiple myeloma, irrespective of whether they have any bone disease that we can detect with the X-rays, they should all get the once a month bisphosphonates, either zoledronic acid or the pomidronate. And we think they should get it for at least 18 months to 2 years, and then we can potentially scale back on that depending upon how the myeloma is doing. Infection is a big problem in this disease, and as most of you know, when the myeloma gets diagnosed, the immune system is kind of compromised, and there's an increased risk of getting infections. And we have to be watching out for those. Sometimes we use prophylactic medications like acyclovir to prevent shingles or antibiotics to prevent infections, even sometimes immunoglobulins to try and prevent infections in patients who have very low levels of immunoglobulins. Anemia is another common problem. We don't use erythropoietin or hormones which stimulate blood cell production primarily because they do increase the risk of blood clots. Having said that, there are some patients who might benefit, especially the ones who have problems with their kidneys as well. Blood clots is a big problem, and obviously patients who are getting medications like the Revlimid or the Pomalidomide, which increases the risk of blood clots, we do preventive strategies, most commonly aspirin, but sometimes patients may need blood thinners if they have the increased risk of getting blood clots. Finally, kidney function. Many patients may present with, almost a third of patients have some degree of renal problems when they're diagnosed. 5 to 10% of patients may have severe renal problems requiring dialysis. Now, clearly, that can compromise the ability to use all the medications we have in the armamentarium. It also allows us or makes us maybe change the doses of some of those medications to allow us to give those medications. So how do we put all of this information together? And again, you will hear different ways of approaching this, and I would say that there is no one single way that every patient has to be approached. As we know, this disease is very different, and everybody has to be treated in different ways. But at least in our group, what we have done in the past is to develop a system where we can actually look at the risk factors. And we know that if patients have any of these markers, which we know are usually associated with more aggressive disease, we tend to treat them more aggressively with a combination of all the medications we have, and obviously treating them for longer periods of time. Whereas if you have something that is in between, like these abnormalities that are shown here, then we tend to treat them with maybe not all the new medications up front, but making sure these patients do get a Bortezomib-based treatment, especially something like what we call the Cybo-D or the Cyclophosphamide, Velcade, and Dexamethasone, and again, keeping them on therapy for a longer period of time. However, if they do not have many of these adverse or the poor risk factors or red flags, then we feel that those patients we may not need to be very aggressive, and we could treat them with one drug at a time and just keep the next one for a later time point. So I think, whether we treat them one way or a different way, we all have, again, differences of opinion between us. What we cannot dispute is that patients are doing better, and even the older patients are doing better, and that is the most heartening fact. And this is just looking at the past 10 years. If you look at the older patients, you know that the patients who were diagnosed in the past 5 years are doing much better than the patients who were diagnosed before 2005, showing that all the progress that has been made in terms of understanding the disease biology and bringing the new treatments to the clinic, and also judiciously using the treatments, have translated to patients living longer. Of course, we still have work to do if we want to keep bringing this line up. And I'll stop there, and thank you.
So thank you so much, Shaji, for this excellent overview of the approach to the older patient with myeloma. I think we have time for some questions, and if our panel could come on back up and help us answer some of these questions, that'll be great.
So the panel's getting enough exercise today for sure.
Yes, a little bit of exercise. Okay. I think, is it Dave? Yeah.
Coming up, I'm going to have this nice lady stand up and ask the first. Oh, come on.
All right, so.
Do you know if Medicare has a protocol? What is their protocol for transplants for elderly patients? Is there a...
What are the Medicare rules with regard to transplants for older patients? You want to, yeah.
So we have always felt that they won't allow for more than one, they do allow for one transplant for sure for patients over 65. But I think increasingly we are finding out they might actually even provide for a second transplant, even in the older patient group. So.
But the upper cutoff, I think, is currently 74, age 74, or is there no cutoff?
It is so
Confusing?
different states
Yeah. Oh, yeah. Okay, so
different states have different policies, and different institutions have different policies. You know, what we have found, but again, it may be unique to the Philadelphia area or Pennsylvania, whatever, is that if you have an appropriate candidate for such a procedure, it seems to happen. So I wouldn't use that as an automatic, we can't or cannot do it, but you got to do the right thing, and it may be an obstacle. Certainly, it seems to be where the real obstacle occurs sometimes is multiple transplants.
Yeah.
And so it is a very confusing area.
yeah, so I would agree, though. I think if you have an excellent candidate and you approach for coverage, you can normally get it. A double transplant may not be so easy.
Hey, Suzanne, in your area?
Okay,
Debbie?
Debbie and Dave, the
I'm
duo.
back again. Thank you so much for your presentations. I really enjoy them. This is more of a personal observation. I'm on a clinical trial with Bendamustine and Pomalidomide and Dex, and they put me on Cipro. And within 3 days, I noticed a heart side effect. That it's all listed in the literature, but in my case, it was real. So I contacted the research nurse and we dropped the Cipro immediately. I went to a doctor, they did the EKG, no heart problems. So
So
if
you developed a rapid heart rate?
very rapid heartbeat.
Yeah.
So, you know, if you're on Cipro and some other drugs and you notice that, don't wait.
Right. Okay, I don't know. Have you guys seen this with Cipro? I have to say that's not something that's that common in my experience, anyway.
So I would attribute that more to the pomalidomide,
Yeah.
to be honest. Yeah, because we give a lot of Cipro, yeah.
I don't know.
So it's difficult to find out what was what.
Yeah.
Because
I don't know. What do you?
I mean, I think, that's just, I think what you just said highlights one of the problems that we're going to start facing as we use multiple drugs together. I think it's more, we just need to be cognizant of the fact there could be side effects that we see with two drugs being together versus each of them being alone. So something that, see something abnormal, something different, persistent, you just need to take each one off at a time and figure out what's happening.
Yeah, all of these new combinations are trials, and they do require trials to make sure there's not some crazy interactions. Okay, other questions?
Kelly, in your...
Kelly, okay.
Doctor, if you have an elderly patient who is throwing clots, but they're also a fall risk, perhaps due to peripheral neuropathy, would you treat them in any way other than with anticoagulants?
Right. I think two things, because that is not a situation that we uncommonly see as we use some of these drugs which can have the neuropathy side effects and also the drugs which can have problems which increase the risk of clotting. So I think if somebody is at risk for getting blood clots, we certainly need to have them on blood thinners. What we can do is to sometimes, two things. One is obviously the drugs we use, we want to try and use the drugs which has the least likelihood of that happening. But despite that, if they are on one of the drugs which can cause it, we want to use something like, let's say, low molecular weight heparin instead of using the coumadin, which sometimes gives you a much more stable levels of anticoagulation compared to the coumadin sometimes can be really back and forth, especially if you are on steroid medications. So those are some of the things that we can try to mitigate the risk, but I don't think we can completely take it away with the drugs we have.
Right. All right. Any final questions here? Maybe one or two more right in the middle here. All right.
I noticed that you recommended for anemia,
Erythropoietin, yes.
Now, is this for the kind of anemia that does not involve iron deficiency or vitamin B12?
That is right.
Yeah.
So the erythropoietin, it's the main area that erythropoietin is being used for boosting the hemoglobin is in the context of somebody with kidney failure. So in myeloma,
And bicycle races.
bicycle races.
Yes. Okay.
So in the context of in myeloma, what happens is if we have an effective treatment and the myeloma gets under control, the anemia usually improves, and we don't have to resort to using any of those things. Where we end up having to use that is usually patients who also have kidney failure because of myeloma. We tend to use that. But always keep in mind that the erythropoietin does increase the risk of blood clots. So if somebody is on something like Revlimid or thalidomide or any of the other medications that increase the risk of blood clots, we try to avoid using that. But certainly not in people with iron deficiency or B12 deficiency.
If you're just smoldering and you have some mild anemia, would you take it?
No, if you are smoldering and the anemia is, if you have significant anemia and smoldering and it's related, then it's not smoldering anymore. But
Right.
if it is significant.
Yes.
And now if that anemia of 9.9 is due to the smoldering, then it's no longer smoldering. It's definitely myeloma that needs treatment.
Need to move into some different therapy. So at the back, Debbie has got a question at the back, and then we can come forward again.
I was diagnosed 6 months ago. I've been on Cybor D. I'm in partial remission. Everybody thought I would be a wonderful candidate for stem cell transplant, but I was thrown off the island because the last test they took was lung function. I have moderate loss of lung function, and I believe it's the Melphalan would possibly kill me, so the facility I went to would not give me a transplant. Is there any other drug, or are there any other facilities that would take a chance with me that I should perhaps visit?
I think it would be reasonable to go to another place, which, especially a center which does a lot of transplants, to get a second opinion as to whether it's really, it's appropriate to take you to transplant. Now, the reason why we don't take patients with significant lung problem to transplant is, infections are very common post-transplant. And if you get, let's say, pneumonia post-transplant, if you already have compromised lung function, then it becomes very difficult to get you through the transplant.
That facility didn't want their numbers to be skewed in the event that I passed away?
I doubt it, but I think it's, I think from, looking from your perspective, I think it's definitely important to get a second opinion. And I will
The way they make a decision about candidacy for transplant, I'll talk a little bit about that in a minute, but it's really puts together a whole bunch of pictures, age, performance, blah, blah, blah. So maybe that was the last straw, in terms of doing that. But in general, a mildly abnormal pulmonary function test is not usually enough to exclude someone from a transplant.
One other question, would it be worthwhile if they harvested my stem cells now in case there's perhaps a new drug that's coming on the market instead of Melphalan, if I pronounced it correctly?
Yeah, obviously it depends on the particular
Could
person.
be considered, I guess. Okay, I think we just need to take one last question and then move on.
I was just wondering what the current thinking is on the use of Iridiazole in terms of its long-term effects and how long you should be on it, etc.
Well, maybe we can defer that. Dr. Lynch is going to be talking about bone and the like after lunch.
I did talk about
Yes.
in my talk and will address that problem.
Yes, it's an important topic, and we'll touch on it a little bit, okay? All right, well, thank you, Shaji. Thanks to our panel. So I'm very pleased to welcome now Dr. Ed Stadtmauer from University of Pennsylvania. He's had a long-standing interest in myeloma, and particularly in the role of transplant in myeloma. And so I'm very pleased to have Ed here to discuss the role of transplant for myeloma patients. Dr. Stadtmauer.
To be here. It's going to be snowing again in Philadelphia. I think we have 58 inches so far this year. All right, so I'm going to talk to you about stem cell transplant. I'll go from what we know to a little bit of science fiction by the end of the talk. This of course, are the cells that we're trying to zap. This is officially a bone marrow aspirate with sheets of these plasma cells. Usually you see only 1 to 5 out of 100 in the bone marrow. And I always feel, sort of what we were talking about earlier, that it rationalizes the fact that I'm a specialist in general internal medicine before becoming a hematologist-oncologist to be a myeloma doctor, because it can manifest itself in so many different ways, with bone lesions and kidney problems and low blood counts and infections, et cetera, et cetera. So, and it's really these manifestations, more so than these plasma cells, that we're trying to both prevent and make better. And you can't forget that it's not just a disease of the bone marrow, it's a disease of your whole body, and we want to keep things from crumbling. And as you've heard, that this is a disease of adults, and it's of all ages in adults, but about half of the patients will be over the age of 70. And so when thinking in terms of treatment options, age is something that comes up. And as Shaji's survival curves keep being shown, there really are major advances in the outcome, in the prognosis of patients with myeloma over the last couple of decades. And I would say that particularly for the younger patients, as you saw from his presentation, that to a real extent is because of high-dose Melphalan and an autologous transplant, in addition to the newer agents, because these, in the early 2000s, we didn't have lenalidomide, Revlimid, and Velcade, et cetera, and yet the survival was improving. Myeloma is the #1 reason that we do stem cell transplants in the world. Second is non-Hodgkin's lymphoma, and acute leukemia, which most people probably associate with transplant, is actually the third most common. But it's really, really important to differentiate donor transplant from autologous transplant. Remember, for leukemia, where the #1 type of transplant we do is a donor transplant, finding a brother or sister or someone who's unrelated as the source of cells. In myeloma and non-Hodgkin's lymphoma, we're primarily using the cells as rescue, as supportive care. And remember, it's the chemotherapy that is the therapy. So we always talk about transplant, but really we should talk about Melphalan, because it's really just a way of incorporating Melphalan at a good dose into the patients with myeloma. And from the 90s and the 2000s, we've had good comparative trials that show that if you incorporate a slug of high-dose Melphalan and a stem cell transplant into the initial line of therapy of patients with myeloma, that you will improve survival. In fact, some of these studies show a doubling of the likelihood of being alive and of having no myeloma 7 years after a stem cell transplant. And there's even some studies that suggest that doing 2 is better than doing 1. And it seems like doing 2, if there is a benefit, is primarily for the people who still have evidence of disease after the first one, but have tolerated the first one and have responded to the first one. But there are reasons to not do this, and these are the sorts of things that we think about. #1 is, what are the risks of side effects? And we sort of had a little bit of that issue with the question earlier. And things that will predict an increased risk of side effects is, as you get older, as you are frailer, And the term we use is poor performance status. If you can't get out of bed well, you're not going to do well getting a stem cell transplant or really with any therapy. If your kidneys aren't working and you're on dialysis, et cetera, that increases the risk. But there's also, so there's the risk of toxicity, but there's also the risk of it not working. You know, the risk of progression despite these therapies. And that's where it's the biology that seems to be coming in. Things like high-risk cytogenetics that you keep hearing about from MSMART, et cetera. Bad biology, high beta-2 microglobulin, that test that you've heard about, tells you that the cells are rapidly dividing and pumping out this protein. And people who have disease outside of the bone marrow, people who have what we call plasma cell leukemia, or lumps of plasma cells all over the place, don't seem to have a poor biology. When we think of frailty, or when we think of candidacy, our pendulum is actually moving away from age, though obviously age is a surrogate for a lot of these things. But age over 75 certainly is starting to be an older group of patients. And then the frailty, and really it's whether you can care for yourself. There are people who are 85 years old and are doing more things than I can do. And then there's people who are, like me, who may not be good candidates for stem cell transplant. There are, and then of course, comorbidities, cardiac, pulmonary, hepatic, et cetera. And, based on these sort of factors, we can sort of get a sense. So it's not just one factor. In fact, at our institution, we call it Esther's rule, because Esther was the first nurse practitioner I worked with. And her rule was, if you had one of these problems, no problem, we can usually get people through the transplant just fine. But if it's two or more, that's when you start having problems. So we call it Esther. So you have to pass Esther's rule at our place. We've talked a little bit about cytogenetics. I'm not going to talk too much about it. I must admit, even though there are chromosomal abnormalities that we can find in the tumor cells. And this is always really important to remember. These are not chromosomal abnormalities or genetic problems that you're born with or that you pass down to children. These are chromosomal abnormalities that are just in the tumor cells themselves. And so they're markers of the cells, and then when they go away, it means you've killed off all the myeloma cells. So if you find these in the tumor cells, there are certain ones that tell us these patients have a much more rapidly dividing disease. And that's going to happen with whatever therapy you give them almost. And so I must admit, I don't use this data that much yet in clinical practice. I think it's really important to get this data for whenever you're looking at a new therapy or when you're comparing one therapy to the other. You want to make sure that the patients are balanced. But it's really hard to say, oh, if you have a 17p deletion, then this is the right therapy. Because as of this moment, we don't have that. But we're looking. And that's why it's so important to participate in these clinical trials. So the strategy for the not frail younger patient with multiple myeloma is the strategy that I've laid out here. Basically, you start off with therapy to debulk the disease, put the patient into a form of remission. Then you, what we call that induction or initial therapy. Then you go on to what we call consolidation therapy, where you give a big slug of high-dose Melphalan, again, using the stem cells as rescue. And then knowing that despite all that, there's still likely some disease, we've learned that we need to chip away further at those last few cells with either some consolidation therapy or some sort of long-term maintenance therapy. So it's this debulking process, and that's where what Dr. Lofgren's data is going to come in, is that hopefully we'll be able to come up with some concoction that makes it so even the minimal residual disease testing shows nothing. And then potentially we might be there to finding a treatment. And I'm sure many of you most of you are aware of how this happens, but remember, once a person has had that initial therapy, we then have to harvest their stem cells. And the way we harvest their stem cells is in the old days, we used to suck bone marrow from the hip bones and freeze it away. We don't do that anymore. Nowadays, that we just give a medicine to stimulate the stem cells to come out of the bone marrow. Those are the cells from which all the bone marrow is made, and we stimulate to come out into the blood. And we simply stick one needle in one arm, one needle in the other arm, or more commonly, we have the radiologist put a double lumen pheresis catheter in the vein. You're sitting in a chair watching television, blood gets comes out, goes into the machine plucks out the stem cells, and then the rest of the cells go back in. So it's like a dialysis procedure, and we do that for 2 or 3 hours, and then we do that for 2 or 3 days in order to get enough cells to do multiple transplants. We then freeze it away. Once it's frozen away, it's good for the next 25 years, maybe. Then we give then once we have that frozen away, we bring the patients either into the hospital, or many centers do this sort of as a pseudo outpatient procedure, and it's just a 1-hour drip of high-dose Melphalan. That's the treatment. And the next day you pee out the chemotherapy. The next day we give you the stem cells as a blood transfusion back, and that's the transplant. It's a 3-day procedure. But then comes the side effects of a transplant. Blood counts go down. People can get a fever and need antibiotics to keep from getting infection, need transfusions of red cells and platelets to keep from bleeding, and can sometimes have irritation of important organs, which is the reason why we do these tests of the heart test, lung test, kidney test, et cetera. Make sure those things are working okay. In the end, over 95% of people do just fine with this procedure, but still 1 or 2% of people can die of a stem cell transplant despite all these tests and all this stuff of infection, bleeding, or some organ dysfunction despite all this other stuff. But the vast majority of people, the real side effects of a transplant is feeling tired, fatigue, and actually the mucositis, the lining of the mouth and the intestines, et cetera, they can get irritated even despite all the best care, and that tends to resolve. So just to give you some idea of the current thing. So that's the transplant. Goals of induction. So that initial phase, the goal of that initial phase is to have a rapid, frequent response. You want to have a deep response. You want it to be lasting. You want to improve the performance status. Another thing that's really important is you don't decide whether somebody's a stem cell transplant candidate at their diagnosis of their myeloma. That's too early. You got to give this stuff, and most people get better. Their kidneys get better. They feel better, and it's really right after maybe 3, 4, 5 months of this stuff, when people are really feeling good, that's when you make the assessment. And when you choose these initial therapies, you just want to make sure you're not choosing a therapy that might destroy the bone marrow and make it so that you can't collect the stem cells. But nowadays, that's very uncommon. That Melphalan pill, in fact, now from the big study that Shaji was telling us about, we know that we really don't even have to give Melphalan anymore, even for the older patients. So anyway, as you've heard, there are some relatively common concoctions that people are getting nowadays prior to the stem cell transplant. One of the more common ones is the combination of Revlimid, Velcade, Decadron, lenalidomide, Bortezomib, and Decadron, where the vast majority of people will respond nicely to this. Paul Richardson, Ken Anderson's work. The Cyborg-D stuff you hear a lot about. It's just Velcade, Decadron, and Cytoxan. What's nice about it is it's a weekly spritz, and you don't have to be as concerned about kidney dysfunction, et cetera. Very nice responses, high response rate. And then even recently, from the recent medical meetings, we've learned that if you bring Carfilzomib, the upfront with lenalidomide and Decadron, you're seeing even more amazing responses. Look, almost 100% of the patients respond with very high incidence of responses. So we're seeing very nice responses. So of course that asks the question, in this era where we're having all these beautiful responses, is there still a need to do a stem cell transplant? And that's a good question. And all I can say is that with all the studies so far that have been done, and of course these studies lag the advancing treatments, that high-dose Melphalan and stem cell transplant still continues to add something. It adds a deeper remission, a longer response, and potentially survival. Just one example is this study that was presented at the big medical meetings from Italy, where they used Revlimid as initial therapy along with Decadron. And despite using that medicine and having patients randomized to 2 transplants versus a Melphalan-containing non-transplant regimen, the people who got the transplant were much more, and did not actually have a better remission rate, but they had a longer duration of remission with the transplant than they did without a transplant. So there's a big study going on right now, a really important study that should hopefully, which is going to use that RVD regimen. And this is also led by Paul Richardson and Ken Anderson at the Dana-Farber, but it's a big national and international effort where a coin flip is going to occur. Everyone gets this initial therapy, and then everyone gets stem cells collected. And half the people are going to go on to more RVD and a maintenance program and only get a transplant when they relapse. And the other half will actually get a transplant in that initial line of therapy and really see once and for all in the current era whether there's any difference. So we await those results. What we do know, though, is that if you do a transplant, there's now a number of studies that show that it's not enough. I mean, in the old days, we used to be one of the reasons why we liked doing stem cell transplant, because it was a blessing in that we could stop other therapies. You get a transplant and then you'd have some period of time where you're not under any therapy. And then only when it progressed we gave therapy. But there's now a number of studies that show that even if you have a transplant, if you take lenalidomide, if you take a little bit, a lower dose of Revlimid after the stem cell transplant versus placebo, it is better to take the lenalidomide. There's both longer duration of remission, and in some of the studies, overall survival advantage. People live longer if they take Revlimid after the stem cell transplant. So some combination of initial therapy, a stem cell transplant, and some form of maintenance therapy, most commonly lenalidomide, has become the standard of care for a patient with who is under age 75, under age 70. Now, a study that just completed in November, but we don't have any results yet for, is asking the further question about the intensity of the line of therapy. As I've said, initial therapy, one transplant, and lenalidomide maintenance, that's sort of the standard of care at this point. Well, what about the two transplants? This will be one of the first studies that really will hopefully once and for all ask the question of one versus two transplants, and everyone gets lenalidomide maintenance. So in a couple of years, we hopefully will have the result. 750 wonderful people signed up to try to answer this question. Additionally, there's another arm that asks the question if after the transplant, it's better to sort of more intensively chip away at the cells with some more cycles of Velcade and Revlimid and Decadron, and then lenalidomide maintenance. So this will be a very important study to figure out. You've heard a little bit about allogeneic transplant, and it's allogeneic or donor transplant makes so much more sense than an autologous transplant, because this is a disease of the bone marrow. Why don't we just destroy the bone marrow and squirt someone else's bone marrow in there and completely replace it and fix the disease? And there are definitely people who've undergone this procedure and are long-term doing well. Maybe 20-25% of the people who've gotten such a procedure. The problem, though, is, of course, anytime you squirt someone else's bone marrow into you, that bone marrow sees you as foreign and can attack you. And we call that graft versus host disease, and that can attack your skin and your gut and your liver. And so there's a toxicity to a donor transplant that has to be weighed against the potential benefits. And in fact, there's a big study that has been done that compared, in fact, 2 auto transplants to an auto followed by an allo transplant. And for the standard patient, there was no incremental benefit. But there are still high risk or biologically high risk patients or there are selected patients where this is still being considered, or people who have demonstrated that they're not going to do well with standard therapies. They've had therapies and then relapsed. Those are the patients now that we're targeting for looking at this sort of thing. This is the big study. 710 patients were enrolled in the study. No benefit for the standard risk patients. There were more side effects, and that counterbalanced the immunologic decrease in relapse. But what these donor transplant studies did show was that there was some capability of the donor immune cells, those are T cells, to eat up myeloma cells, so a graft versus myeloma effect. The problem was the toxicity of having them also eat you up, which we don't like to see too much. So the central, so what is the newest sort of thing that you might have heard about is the idea of trying to harness this immune anti-myeloma effect without giving the graft versus host disease. So the central hypothesis of these cellular therapies is, why don't we improve the ability of these T lymphocytes, these lymphoid cells, to kill cancer, modulate the immune system. And if you use a person's own immune cells that are obviously incompetent, or else you wouldn't have myeloma in the first place, but if you could engineer them to be anti-myeloma, that might be a way of not getting the graft versus host disease, but get the graft versus myeloma effect. And so an autologous transplant is potentially a friend with benefits. And the transplant might be a way of really reducing the amount of disease, but also stimulating the immune system to allow for these other immune system, or these immunologic techniques to occur. And it's really the technology over the last decade or so that allows us to do this. This is an example of how we can actually take, just the same way we take the stem cells, the hematopoietic stem cells out of the blood, we can take the T lymphocytes out of the blood of somebody in the same way. You know, we stick one needle in one arm, one needle in the other arm, the blood goes into the machine, and we pluck out those lymphocytes. Outside the blood, we've got some very sophisticated techniques to, and those larger cells are the T cells, and what's next to them are these magnetic beads that that have been engineered to make these T cells think they're being infected. And so they get really angry and active and inflamed. And that then and depending on how they've been manipulated, it makes them grow in numbers, and then we can get tons of these cells and then squirt them back in afterwards. So as I said, a patient, and sometimes we sort of prepare these cells by vaccinating the people against myeloma, or at least we hope we're doing that. Sometimes we just take out the cells and then outside the body engineer them. And so I wanted to show you some of the very, very preliminary data of these sorts of treatments. So this is just 13 patients in a multi-center trial where patients were given a vaccine. It's called against MAGE-A3, which is something that is frequently in myeloma cells. And it tends to promote the proliferation of myeloma cells. So if you give someone sort of think of it like the flu shot, you give them a flu shot, then 2 weeks later you take out now these immunized cells, you cook them up so that they're potentially more active, and then you can give shots of this vaccine of anti-MAGE-A3, and in this case, this did not show an effectiveness in terms of killing myeloma, but what it did show was that in these patients you could stimulate an immune response against the myeloma cells. So that's sort of cool. There's another study. This is also centered at the Harvard Consortium of Hospitals, where before a transplant or before even initiating therapy for patients with myeloma, they take out some myeloma cells through that bone marrow aspiration process, and they have been able to make a fusion vaccine, a vaccine that actually is a sort of a combination of the myeloma cell with a antigen-presenting cell or a dendritic cell, which is a very immune-active cell, and they can make this combined fusion vaccine and give that to patients afterwards. And there's soon going to be, and they've shown in preliminary results very nice responses and very nice both response rates, people going to a nice remission, and that have even been prolonged. There's going to be a big national trial utilizing this in multiple institutions and see if we can further improve or replicate that data. What you'll hear a lot about in the news comes from our center, which is what we call chimeric antigen receptor modified T cells, or CARs. And in this case, what we do is we take a person's own T cell and we actually infect the cell with a lentivirus that has in it a gene that makes your own T cell put on its surface warheads that will attack the tumor cell. And then we do what I said, once we have those cells engineered, we grow them up and then squirt them in after either a transplant or by themselves, and they attack the tumor cell, the myeloma cell, and kill the tumor cell. And currently, the only the one that we have actively in clinical trials attacks any cell that has CD19 on its surface. Well, it turns out that most lymphocytes have CD19 on their surface, but the mature plasma cell does not. So this may not be that effective a therapy for the vast majority of myeloma cells. What we're hoping, though, is that the mother cell, the cell from which all of the other malignant plasma cells are derived, is CD19 positive, and so that's what we're directing. So we're first reducing the patient's amount of disease to minimal amounts, and then squirting in this engineered T cell to wipe up the mother cells. We'll see. The one study that we have done, and incidentally, we've only treated one person with that, so that's still a very early study. There's another target called NY-ESO, where we've developed, which is another thing that's commonly on myeloma cells, and we've developed this one's a T cell receptor chimeric thing, again, infecting the cells and making the cells put on their surface a warhead against NY-ESO, and then we do a standard stem cell transplant and then squirt in these now engineered cells. And we've treated 25 of these patients, and we've seen very nice response rates. Virtually everyone is in a almost CR, if not CR, complete remission. Of course, there's the toxicities of a stem cell transplant. I would say the additional side effect of these sorts of therapies is inflammation. Frequently, there is what we call a cytokine release syndrome, or an inflammatory thing that we've learned how to take care of, but we have to watch for that. So these are not therapies without any toxicities. But there are patients who've had this sort of therapy who are doing well for over a year later. So I just wanted to give you this as examples. I told you I was going to do science fiction at the end, and this is really very new technology, really early stages. It's not the thing that everyone says, I need these cells, because we still have a lot of work to do. But this is, I think, a very important current area of focus. I think we might be at the moment of immunotherapy for myeloma, where we have so many different vaccine approaches, doing it with transplant, doing it without transplant, just squirting in these cells. So to conclude, autologous stem cell transplant continues to have a role in the treatment of myeloma. We're awaiting results of randomized trials of upfront versus deferred, of single transplant versus double transplant. But our general approach is get into some form of remission, do an upfront transplant, save the rest of the stem cells, and do some sort of maintenance therapy. Maintenance lenalidomide improves survival in some, but not all studies. What's the optimal duration? What's the role of other agents other than lenalidomide, like proteasome inhibitors? And then, of course, all of these immunotherapy, cellular therapy strategies are being explored, and they seem to have acceptable safety. They seem to be able to induce antibody and T cell responses, but their true benefit still needs to be figured out. So, thank you very much. I'll be happy to answer any questions.
Thank you so much, Ed. We can have our panel coming back up to cover any questions. We'll do the interactive questions first, yes. So, yeah, stay there. Good job.
So first question, what has been your experience with transplant? One, if you've had 2 transplants. 2, if you've had a single autologous transplant. 3, if you've had an allo. 4, if you've had a mini allo. 5, if you've harvested but haven't transplanted. And 6, if you haven't transplanted or harvested.
Somebody might want to double check the anti-malware.
Yeah, really?
Chinese are visiting.
Snowden.
Yes, yeah. Put a call into Snowden, yeah.
Now, hopefully that'll go away at some point, but if it doesn't, so be it. Okay.
Okay.
So we've got about half the people have had some sort of transplant experience, 10% harvested, but most with a single auto transplant, 40%.
So this is interesting in that the majority of the patients in the room are the more elderly patients. So,
Yeah, that's right.
pardon?
They're young,
Young.
older patients.
Young, older
More
patients.
mature, more mature.
I'll go on a little course and see if I can come up with the right words here.
Alta
Anyway.
talkers?
Anyway, 40% have had a transplant, which is great.
Okay, let's take a quick look, though. If we look at that against, well, that's kind of interesting. If
It's
we look
that
at that
malware.
against how long ago they were diagnosed, it looks like 29% of the people who had single autologous are out more than 5 years, as are half of the people who've had no transplant and no harvest. So we've got sort of a range of experience in terms of how long people have been around.
All right.
Okay, how important is auto transplant in this new setting of novel therapies and combinations? Is it still relevant? One, if you still think it's very important, if you can do it. 2, if you think it's not necessary unless the newer stuff doesn't work. 3, if you don't need to consider it as part of an upfront treatment. And 4, God knows, best to, I think that says best to consider upon relapse, actually. So number 4 is like do it when you have to, when you're running out of options.
So seriously, somebody could click that box on the computer back there.
Don't even try.
No clicking.
Don't blow on it because it'll go into some kind of God knows what kind of seizure.
Oh, all right. Okay. No computer seizures. Okay.
Okay, number 4 again is to do it on relapse.
All right. So.
Okay, here we go.
Still very
so
important,
half of the
53%. Okay.
Okay. Not many people are holding it for relapse. That's interesting.
Yeah. 12% do not need to consider.
Okay.
Okay.
Is maintenance therapy recommended? So once you have the transplant, should you be on some kind of lower dose therapy to keep things under control?
Okay. Maintenance. See what message has been going out here.
Okay, we'll see if anyone was listening. Whoa, okay.
95%. Okay.
Overwhelming for maintenance.
So, strong message.
Okay, and I think we're ready for questions from the audience. If we can put the
Okay, this
logo
will be
back up,
after
please.
Suzanne's stuff. So, thanks again, Mike, for that.
Thank you.
Double check on your malware.
Absolutely.
Good luck with your computer.
My section?
Thank you. When stem cells are harvested from one institution, can they be transferred to a second institution if a second transplant is indicated?
Okay.
Definitely. There's a nice collegiality among all of the transplant centers. Most of, if not all of us, are what we call FACT approved. There's actually a sort of third party that assesses and inspects these things, and as long as it's one FACT approved center, sending cells to another FACT-approved center. The quality of those cells can be assured, and it's very common to do that. So that's not a barrier. That's correct. And in fact, we don't so I don't know how other centers do this, but we do not charge for storage of stem cells at our institution. We feel that this is a sort of human endeavor, and so we don't guarantee them, and we don't charge for them. That being said, they tend to be stored in the most compulsive part of our hospital, the blood banks and things like that, and it is very, 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 very rare that there's anything that happens to it. But there's also, but the time that the cells have been stored is part of our decision-making as to whether we should proceed with using them. Because exactly what you're saying, that it's a human endeavor. And so as time goes on, who knows if the freezers have all the right sort of things. And so if somebody is 15 years after their stem cells were harvested, we're probably more likely to think of either alternative therapies or reharvesting some more cells, even if you have them stored away.
You're talking out of turn now.
The shipping,
and I run a tight ship, and we're running behind. So, Suzanne?
I'm sorry, I've made everyone behind.
Could there be a problem during the shipping? Well, FedEx is going to get it there, right?
Once again, I would say that it's a very compulsive, quality-assured process. But exactly what you said, there's not a zero chance of anything. It's a human endeavor.
All right, shorter and funnier.
Okay.
Two questions.
All right.
First,
One question.
will it be possible to get it
All
out
right.
of your slides?
Oh, he wants a copy of your slides.
I don't know. I'll think about it.
He's thinking about that one, okay?
He's thinking about that. Great. Okay. And my real question is, based on the trials that you're doing at the University of Pennsylvania, which ones have shown the most effectiveness in terms of, from the patient's perspective, leading to possible overall survival improvements?
Now, are you talking mostly about those new
fancy ones?
the fancy
That's
ones at the end of the show?
So the reality is the fancy ones are too early to talk about efficacy, effectiveness. They're really, those CD19 cells that I showed you about, they've been used more extensively in other diseases, in chronic lymphocytic leukemia and acute lymphocytic leukemia. There the results look very promising, but definitive trials are still either ongoing or just, so it really has to be thought of as an experimental process that will still take some time to figure out.
And so mostly these are patients who've actually gone through every other kind of therapy.
Yeah, so right, that's right. When I talk about the acute lymphocytic leukemia and the CLL patients, those patients had no other option, really. And it's remarkable that a good portion of those have responded. In myeloma, similarly, the initial studies that we're doing are for people who have very advanced, heavily treated disease before we're going to bring it into the early phase.
Earlier, yeah.
Thank you.
Okay.
Does an allogeneic transplant slam the door shut on participation in clinical trials of new and emerging drugs?
I think that's an excellent question, and I must admit, I think one of the, thanks to, I think, the whole community of myeloma, one of the things that we're always thinking about is keeping options open. And I think we do that when we make our decisions about what treatments we think about. We don't want to close too many doors. And I would say allogeneic transplant, probably more so than others, but not completely, can sometimes close some doors. I mean, sometimes what allogeneic transplant does is cause some gives you some other diseases, this graft versus host disease, et cetera, that might be limiting. There are a lot, I would say many clinical trials exclude people who have had allogeneic transplants in the clinical trials. But I can say that there are clinical trials of new agents that do include allogeneic, some of them, and most importantly, all of the conventional therapies are available for patients who've had, despite having an allogeneic transplant, they'll be eligible for them.
Right. Any other comments on that about allo versus novel agents, or any different perspective?
I mean, I can comment on that. I mean, a lot of clinical trials exclude allogenic transplant patients because it's difficult to evaluate toxicity, for instance, if you're in an early phase 1 trial. For sure, as an allogenic transplant patient, you might have a more higher sensitivity to certain toxicity, hematologic toxicities. But if you're a great candidate, and maybe that's the way for cure, I would consider this strongly because we have so many novel drugs right now which are approved, Pomalidomide, Carfilzomib, that I think the current options are really wide open.
Right. So thank you. I think we have time for maybe one more question, yeah? Then lunch is cooking, or cooked, I hope.
If stem cells are collected and not used, can they be donated to someone else for an allo transplant?
Well, so that's a great question, and of course, when stem cells are collected by a donor, for a sibling or something like that, then those cells are from healthy people and potentially maybe could be used for other purposes. But if you think about it, when your own stem cells, every patient who collects their own stem cells, those patients have diseases, right? They have multiple myeloma or lymphoma or whatever sort of things. And so there is really, that's really excludes them for use in a bank of any sort. So no, we usually don't. Umbilical cords can be stored and used for other people. And, the most important thing is to be on a bone marrow transplant registry, just having your blood type in there, and then potentially that could be used for a wide group of patients with potential problems who need a donor stem cells. The nice thing about stem cells as a donored organ is that it's a renewable resource. So, if you donate blood, even if you donate bone marrow, that will replace itself very quickly.
All right. Okay, so I think we've had a very... All right, so let me just say thanks to Dr. Stadtmauer. And to our panel for the... and to you all for hanging in there during a very busy morning. And so before we break, yes?
So just to make sure that we're not standing in line for too long for lunch, if the back of the room could try and exit out of these 2 back doors, and there's